Sam, that was a bit covered up on my end. You've started the recording of the meeting.
Yes, sir.
Did you grant permission for the news media to also record?
I did.
Okay, thank you. All right, okay. We're going to go ahead and get started. My name is Rick Petrie. I'm the chair of the Maine Trauma Advisory and Prevention Committee. I'd like to welcome you all to the meeting today. Thank you for joining us. I'm going to start by reading the standard mission language from Maine Emergency Medical Services. The mission of Maine EMS is to promote and provide for a comprehensive and effective emergency medical services system to ensure optimum patient care with standards for all providers. All members of this committee should strive to promote the core values of excellence, support, collaboration, and integrity. In serving on this committee, we commit to serve the respective providers, communities, and residents of the jurisdictions that we represent. I'm going to take roll now so that we can establish a quorum for the meeting today. Dr. Matt Scholl.
Here, thank you.
Dr. Amy Fenwick. Thought I saw Amy on. Okay. Dr. Stephanie Joyce.
I am on here. Thank you. Sorry, I did unmute.
There we are, Amy. Dr. Stephanie Joyce.
Stephanie's not a member anymore.
Oh, sorry, my fault. Should read my own notes. Thank you, Kate. Dr. Richard King.
Here.
Dr. Joe Rappold.
Here.
Dr. Pete Tilney.
Sorry, I couldn't get off mute. Here.
Dr. Guy Nuki. Director Sam Hurley.
Present.
Lindsay Gardner. Anna Moses.
And it's here.
Steve Richards. Joanne LeBrun.
I'm present.
Thank you. Tom Judge.
Here.
Chris Perret.
I'm present.
Thank you, Chris. Ben Zetterman. Leslie Anderson.
I am here.
Dr. Christopher Bowie.
Present.
Mindy Gammon. Chris Costello.
Present.
Tammy LaChance.
Present.
Julian Tango.
Present.
Prep Jorn.
Here.
And I am here. 1, 2, 3. There's 17 members present. We have a quorum. So we are going to, so I want to take this opportunity to welcome everybody. I do want to start with an opening statement. Before we begin, it's important to acknowledge the significant role that Central Maine Medical Center has played in the development, maintenance, and evolution of Maine's trauma system. The engagement of the CMMC staff, in particular the early work of Dr. Larry Hopperstead and others, helped set the foundation of the collective trauma system, a system based on inclusivity, which at its core implies collegiality and cooperation. We are all practicing in unprecedented times, but as we address these issues today, we must exemplify the same collegiality and cooperation that our system and our patients demand. In addition, as we address the uncertainties that these conditions present, we must maintain our collective patients and their outcomes as the guide that directs our decisions. The goal for the meeting today is for the TAC to determine how we will move forward to support our patients, our EMS providers, our institutions, and our trauma system. Before we proceed, we should set the meeting's rules of engagement. We request that everybody is on mute and must raise your hand if you wish to speak. When you speak, please state your name and your position on TAC on the committee. Please place your camera on while addressing the group. We will not be taking public comments or questions today, and this meeting will be recorded as you've seen. So with that having been said, I would like to invite Jason Krupp from Central Maine Medical Center to give us an update on their Central Maine Medical Center's neurosurgical coverage.
Thanks very much, Dr. Petrie. My name is Jason Krupp. I am the president of Central Maine Medical Group and the chief physician executive for Central Maine Healthcare. And I appreciate this committee taking the time today to allow me to update you on our current neurosurgical coverage situation. For the next 60 days, we will have sporadic neurosurgical coverage. We have nothing left from a coverage standpoint in December, and we'll have 7 days of coverage in January. Past those 60 days, we will no longer offer neurosurgical services for trauma. We will continue to be a tertiary care referral center, offering the same surgical specialties to the community and state, with the exception of neurosurgery. We'll continue to have 24/7 coverage by our trauma surgery group and our orthopedic surgeons. We will continue to be able to handle complex multi-system trauma patients as we have in the community and the state for many years. We continue to grow our outstanding cardiovascular, orthopedic, stroke, and oncologic programs. We'll continue to follow normal protocols. Anybody who shows up in our emergency department through the doors, we will continue to care for. As is typical, if they require neurosurgical services, we will stabilize and then prepare for transport to a system that has those neurosurgical services. I'm grateful. I recognize that these unprecedented times have created a relatively speedy change here. That said, we at Central Maine Healthcare are committed to play any role we can going forward in supporting EMS and this committee to care for the people of this state as our neurosurgical capabilities change. So I'll stop there.
Great. Thank you, Mr. Krupp. I really appreciate that. Just for the record, since we are being recorded, I appreciate the promotion, but I'm a paramedic and not a physician.
I appreciate it. And I'm an internist, not an ER doc. So
Well, there.
I do my best.
Thank you for that clarification. So in front of the Trauma Advisory Committee today, we need to talk about our next steps for the system. I really want to thank Dr. Krupp and Central Maine Medical Center for coming to us today so that we could talk about this. Based on the state trauma plan and the operations of the committees as a committee of the Maine EMS board, we have two choices as a group moving forward. The first is we would defer to the language in the state operations plan and request that the Maine EMS board appoint a subcommittee to talk about the plans of Central Maine Medical Center, what their future plans are, analyze the data coming out of Central Maine, and then make a recommendation back to the Maine EMS board as to how we should move forward. Our other choice is, if this group were to so decide, is that we would move forward as a full committee to discuss all of these issues before us today as the full committee, and then develop a recommendation for the Maine EMS board. Does anybody have a question about either of those two options in front of us today? Or questions or comments about a preference on which path we should go? Director Hurley.
Thank you, Rick. So my inclination is that the trauma plan was not written to take into account the fact that there's a global pandemic, a staffing shortage, interfacility transport concerns or delays, as well as an abrupt leave from the established level of care. And so I would recommend that the committee take this up today, and start addressing this, with the potential outcome at the end of this meeting is for us to convene a committee to look at what the future looks like from tomorrow on. But I think the EMS clinicians in the state of Maine deserve today an answer from this committee of what they should do with critical trauma patients in the central Maine area. And so I think it's prudent for this committee to make some decisions and provide some guidance to EMS clinicians throughout the state now, because the clinicians shouldn't have to be making decisions in the field on some information. They should have clear, direct, transparent guidance. And I think that this committee should provide that guidance today to the best of our ability, and then potentially offer follow-up guidance with a committee should this group so choose.
Thank you, Director Hurley. Dr. Scholl.
Thank you, Rick. I would agree with Dr. Hurley, and I would just also offer that some of the elements and values that have made our trauma system so successful historically have certainly been the hard work of hospitals like Central Maine and the other regional trauma centers, as well as the trauma system hospitals. But along with that hard work and the tenet of inclusivity that you mentioned earlier, Rick, I think another element that makes our system so successful is transparency and our ability to message clearly with each other. And with such a change occurring, I think it's imperative that we are transparent in the messaging we offer, not just our EMS colleagues and clinicians across the state, but our partner physicians and other hospitals across the state as well. So I do echo Director Hurley's sentiment that there is some level of imperativeness to deliberate about this today.
Thank you, Dr. Scholl. Director Hurley, I didn't hear if you, just a quick question, if you mentioned it, you spoke about the difficulties with interfacility transport. Did you also speak of the difficulties with maintaining coverage in the service's primary coverage area?
No, but that's also a concern. But whether they're going to Central Maine or whether they're going to Maine Medical Center or Bangor, when we take an ambulance out of service to take care of our patient, it's going to take time. I think the conversation around how long is certainly something that we will need to address going forward if we have further conversations about, for instance, changing the 45-minute period that we have looked at previously. But I think that's a conversation for further down this line as we move through this process. But I certainly think that is something we would need to consider.
Great, thank you. Do any other TAC members have any comments or questions about our options in front of us today? Prep Bjorn.
Yeah, Rick, I think we need to consider this in two different directions. One is the obvious neurosurgical emergencies and how we deal with them in that region in terms of bypassing CMFC to get those sick patients to neurosurgeons as quickly as possible. But I also think we need to consider the patients who don't declare themselves as neurosurgical injuries. How do we identify and triage them? Is there a role in a non-verified, or at least a non-level 1 or level 2 verified trauma center to screen those patients? Will we be promoting more secondary transfers if CMFC intervenes in certain patients who are later identified to have head or spinal injuries? I think those are two different questions that need to be answered, and they may end up with the same answer, but I think we need to deliberately answer them separately, because I do think that the priority for the major neurosurgical cases is to get them to a neurosurgeon at a trauma center.
Thank you, Brett. I appreciate that. Chris Perret.
Thank you, Chair. Chris Perret, EMS provider. I feel like the issues in front of us deserve the attention of the full committee and that we should hear them today. We can make a decision after we've heard everything about what our next steps are moving forward. However, in a world that is overwhelmed with subcommittees that are of marginal effectiveness, I think that the priority and the urgency of this particular issue merits discussion today. Thank you.
Thank you, Chris. Dr. Rappold.
Yeah, Joe Rappold, TMD Maine Medical Center. I echo Matt Scholl's comments that we need to leave here today with as much clarity and as well as Sam said, as humanly possible for our EMS providers. Where do they go? When do they go? Who goes where? We need to spell this out to as fine a detail as humanly possible. Making a pit stop at Central Maine for a neurosurgical issue does not serve the patients well, puts Central Maine at risk, and ultimately results in bad outcomes.
Thank you, Dr. Rappold. Do any other Trauma Advisory Committee members have any comments, thoughts, questions? Brett, did you raise your hand again?
I did. I'm sorry. The other, I think, and now I'm scrambling to find out what I'm trying to say here. I had another thought and I lost it. I apologize. If I bring it up, I'll raise my hand one more time.
Okay. Thank you, Brett. Any other comments, questions?
Rick, I've rediscovered my memory.
There we go.
So here we go again. I'm going to write it down next time. I had it on the edge of my tongue, and this is embarrassing. I'm getting old. I'll be right back.
Okay.
I think they have neurosurgical services at your facility.
Oh, okay. Now I got it. Okay, I got it. Primary versus secondary service area is the other, and I have no idea where my head is at. But in terms of CMMC, like any other community and hospital in Maine, being able to take patients from their primary service area, even with neurosurgical emergencies, for the purpose of stabilization and transfer, I think that needs to be maintained, obviously. And I don't think we can overlook that. But the purpose of the trauma center mandate for transfers in the trauma system plan is, the idea that you can't accept transfers of major trauma if you're not a level 1 or level 2, I think is important and needs to be maintained.
Thank you, Brett. Tom Judge.
Thanks, Rick. I think that there's pieces of this, and I agree that clarity for everyone is important. I think we shouldn't lose track of, and perhaps at Lifelight we have a unique view because we literally see every single hospital that is moving things all over the state. I think that most of the EMS providers are actually pretty common sense driven, and they know when they need to take a patient direct to a trauma center that may bypass another hospital, and they know when they have they cannot manage this patient and they need to get this patient to the closest physician possible in an ED. And I think they do a pretty good job. I think there's certainly a question that, and that we would see you have a head injury at Sunday River, that patient, is all possible go directed to Maine Med, all things being equal. If you're sort of on the Gray to Gloucester line and you're equidistant, the trauma patient, especially neuro, should probably go to Maine Med for doing things. But I think that the local EMS providers, and we've certainly see the same situation with, very good surgical services in Augusta, is get the patient to the ED that can stabilize them. There may be a surgeon that helps stabilize them, and let that physician then determine the onward transfer for the thing. So I think most of the people are pretty common sense. We run into this all across the state, pretty much every day. And I think the EMS providers are pretty good at making decisions about when they can go direct and when they need to get to the closest physician that can help stabilize that patient.
Thank you, Tom. Are there any other TAC committee members who have comments? If not, I would entertain a motion from the floor for any of either of the two options that we have. Oh, I'm sorry, Dr. King. Please go ahead.
So thanks, Rick. I just want to reiterate, I'm Richard King, the Trauma Medical Director at Central Maine Medical Center. I just want to emphasize Dr. Krupp's point that we continue to provide trauma services to our community and beyond. It's unfortunate, but obviously we will not have neurosurgical capability. But I think that in answer to everybody's comments, yes, we need to have clarity. But I think the wider issues about trauma system in Maine, as far as what we will be going forward, I think that's going to be quite influential to the whole care of the trauma patient in Maine, wherever that patient may be. So I don't know if we'll necessarily be able to answer all those questions, but as far as what we can do as a center to help support our partners in Bangor and in Portland, and also the EMS providers around us, we're going to take a really active role in that.
Thank you, Dr. King. Before we debate which way we should go, I do also want to ask Tammy LaChance is a trauma program coordinator at Central Maine. Do you guys have the data pulled together yet about what the impact on this will be? The number of trauma calls, neurosurgical calls, transfers, things like that?
Hi, Rick. Yes, I do have that data.
Okay. And would you be all set to provide that today if we decide to discuss that today?
I think I'll defer to Dr. Krupp on that.
Yeah, thanks. Thanks, Tammy. Rick, as it relates to those volumes, I think that's going to be part of, it's not that we want to keep that from the group, but it's part of a larger discussion that we're having later this week. So I think as we move towards figuring out longer term how all of this fits, I think that's part of the conversation. I can say in general, the number of neurosurgical cases from a trauma standpoint that come to Central Maine Medical Center makes up 10% or less of our calls here. But in terms of the full scope, I think that's something that we're finalizing that sort of information, and we'll share it in the short term, but we're not ready today.
Thank you, Dr. Krupp. Dr. King, is your hand re-raised or still up from before? Great, thank you. All right, seeing no other questions, I will entertain a motion from Trauma Advisory Committee members on which way you'd like to go. Our choices are to defer to the State Trauma Operations Plan and request the Maine EMS Board form a subcommittee to work with Central Maine and the other trauma centers to develop a plan moving forward, or B, discuss CMMC's announcement today as a full committee and develop a recommendation to the board. Dr. Rappold.
I would propose the second option. I concur with Dr. Scholl that we need to have clarity on this at the EMS level, and it needs to be granular and not nebulous.
Thank you, Dr. Rappold. Dr. Rappold has made a motion to discuss the Central Maine Medical Center announcement today as a full committee and then develop a recommendation for the Maine EMS Board moving forward. Chris, I noticed your hand up. Is that the second?
It is indeed.
Okay. And that motion would be seconded by Chris Perret. I'd open the floor now to any discussion from any of the TAC members about the motion?
So Rick, it seemed that Sam had also talked about a third option, which was to get clarity for the EMS providers on this initial issue. It sounds like there's additional work at Central Maine that's being done. And it would seem that there's probably a two-step process, that getting clarity for EMS providers is important, as people have noted, about what to do right now. And there may be some additional things that need to be thought about on Central Maine. It sounds like they have additional conversations going on.
Thank you, Tom. Dr. Ritter. Hold on 1 second, Dr. Ritter. Tammy, a clarification on Dr. Ritter? Not Tammy, sorry. Kate, if you're still there.
I'm here.
I don't believe that Dr. Ritter is a current member of TAC. Is that correct?
He is not a current member of TAC. He is the regional medical director for that region.
Okay, thank you. Sorry, Dr. Ritter. Brett.
I promise I have it ready this time. I wrote it down. Is there room in here, Rick, to have an interim recommendation from this body while if the board were to receive this? Can this meeting today come up with an interim recommendation, a stopgap plan, a couple small bullet points for some sort of interval clarity while the rest of this goes through a little bit more deliberately?
I believe that this committee could make whatever recommendation they want as a committee. So that could be another option that could come up after we see how this motion plays out. Unless Dr. Rappold and Chris would entertain that potential change to their motion.
Well, I'd be interested to see what Matt Scholl has to say on this.
Thank you. Dr. Scholl.
Thanks again, Rick. I tend to agree with Tom that there are some questions that need to be answered today. I would also, though, agree with Tom that there are other questions that we may want to answer more deliberatively and have more experience and, if not evidence, anecdote behind us as before we make too many major system changes. But I think the most pressing issue and the issue that we have to address today is related to giving very, very fine details to our partner EMS colleagues about how they behave in the context of these current changes. I think we have to answer that today for our EMS system as they enact our trauma plan.
Sure. Are there any other comments from TAC members on the motion on the floor? Chris, I'm sorry, is your hand up new or holdover?
It is up new.
Thank you.
My intent by supporting Dr. Rappold's motion is that we could come to at least some interim guidance today. I was very concerned about putting the entire thing off to another time and leaving the EMS providers hanging. So my intent in my support of Dr. Rappold's motion is that we come to some type of transparent guidance today for EMS providers.
Great. Thank you, Chris. Brett.
Yeah, and I think that that's doable. I think that we could, again, we talked about this offline in previous meetings about other issues where if a trauma center is not able to maintain a level 1 or level 2 verification, that they can close to transfers but continue to receive acutely injured patients. And I think that that might be one among many options for us to consider, but that would also be clear to the EMS providers that they're not doing interfacility transfers of major trauma, that those will go to the level 1 or level 2, but all other trauma in their service area, like in every other hospital in the state of Maine, can go to them primarily.
Thank you, Brett. Does Do any other TAC members have any comments about the motion? Joanne LeBrun.
So I agree with Chris that I think the clarity within, in the short term is really important. I also think that, we have to look at and wisely use all of the sources that we have. And so I would certainly be in favor of discussing, what would be the interim so that we all have time then to come back and to think about what are the longer term effects of this as healthcare is changing and access to resources is changing. So we could discuss this further, as Brett has said, as we have done in the past.
Thank you, Joanne. Are there any other comments from current Trauma Advisory Committee members? Dr. King.
Yeah, I would like also to make a comment about, our current COVID and staffing situation in the state, and that, this situation with our neurosurgical coverage has to be looked at in that vein as well, because, we still are a level 2 trauma center as per the American College of Surgeons. We still have broad trauma capability. And at a time when other hospitals like Maine Medical Center are experiencing, the same kind of staffing and lack of bed availability that we all are, I think that needs to be taken into account as far as how are we going to continue to integrate within the trauma system, accept patients, and go forward, as is the situation with our EMS system, also having staffing issues. So I think those two considerations bookend this problem, and I hope that we can develop some clarity on that coming out of this meeting, if anything.
Thank you, Dr. King. Are there any other comments or thoughts or questions from Trauma Advisory Committee members? Director Hurley.
Yeah, I would just raise a point of order that discussion at this point should be limited to the motion that's available on the floor. And that we should move past this motion and then we can move to another motion or another discussion topic. But I think we need to weigh in whether we're going to have this conversation today or not, and go from there. But I think we should limit further discussion to that specific motion and then take action.
Thank you, Director Hurley. Does anybody have any further comments about this specific motion? Seeing none, I'll conduct a roll call vote. Dr. Scholl.
Can you just repeat the motion for us, Rick, please?
I can. Where did I write it? Okay. The motion is to move forward with a discussion on the CMMC announcement today as a full committee and develop a recommendation for the Maine EMS board at their January meeting.
Thank you, Rick. I'm in favor.
Amy, Dr. Fenwick.
I'm in favor.
Richard King, Dr. King.
I'm in favor.
Dr. Rappold.
I'm in favor.
Dr. Tilney.
Excuse me, in favor.
Director Hurley.
In favor.
Anna Moses.
In favor.
Joanne LeBrun.
In favor.
Tom Judge.
In favor, noting that we don't have any concrete parts of this the recommendation. So it's fine to have a discussion about a recommendation, but we ought to have a recommendation that goes with it to have any proper thing. So going in favor of continuing discussion is fine.
Tom Judge is in favor. Chris Perret.
In favor.
Leslie Anderson,
In favor?
Dr. Bowie,
In favor.
Chris Costello,
In favor.
Tammy LaChance,
In favor.
Julianne Tango,
In favor.
Prep Jorn.
In favor.
Okay. And I'm in favor. The motion carries as unanimous. We will continue the discussion. I put together a couple of questions that I think will at least start the conversation of trying to get as much information as we can to make the recommendation. Central Maine has already said that they do have some data, but they don't feel it's complete enough yet to offer us data on the trauma patients that come in or the ones that they transfer out or neurosurgical, except for the statement that Dr. Krupp made about neurosurgical patients being approximately 10% of their trauma patient volume. Is that a correct statement? Did I get that right, Dr. Krupp?
Yes, sorry. I was having a hard
That's
time finding the mute button.
Oh, thank you. I appreciate that. So not having any data at all that we can use. The first question is how does the loss of neurosurgical coverage affect Central Maine's role as a regional trauma center? According to the current plan, as most of you are on this committee know, that places CMMC as functionally a level 3 trauma program. So the implications of that are that CMMC would not receive interfacility transports or scene trauma calls from Lifelight, depending on the distance from other regional trauma centers affecting 911 transport. So, so the questions in front of us is that's technically how it's laid out in the plan, as pointed out. How would the committee like to proceed with that and that process? I guess the two big questions there are, can CMMC continue to receive interfacility transport patients? And can Lifelight of Maine continue to transport patients directly to Central Maine Medical Center? Thomas Judge.
Yeah, thanks, Rick. I think that's a very secondary piece of this. If we want to give clear guidance to the EMS providers, it's really three things, right? If you have a neuro patient, a clear neuro injury, that the EMS provider should get that patient to the closest regional trauma center with neuro services by the fastest means necessary. You know, and second, that if you have a multiple trauma patient with altered mental status, that patient should probably, same thing, go to the regional trauma center because of, you know, the concurrent injuries. I think that for all EMS providers, if a life-saving intervention is necessary, they should go to the closest hospital trauma center capable of managing that life-saving intervention, and then allow the physicians there to determine if onward transfer is necessary. And then the fourth thing is the interfacility piece of it, which is, I think, probably a much smaller group of patients. And I don't think that's really the clarity for EMS that we need, because the interfacility transfers is really a physician to physician, hospital to hospital function using EMS services. So it seems that if we're trying to keep clarity to the EMS providers, we ought to be very specific about what patients should be redirected to the regional trauma centers with neuro services at Eastern Maine and Maine Med. And then, you know, if there's gray patients, the recommendation on those, the interfacility transfers, I think, is a secondary piece. And it sounded like Central Maine had maybe more discussion and more data to present around that issue.
Thank you, Tom. Dr. Rappold.
I agree with Tom, and I would ask Jason, this is why the data is so important. And I think the interfacility transfers by the EMS or the state plan, Sam and Rick, correct me if I'm wrong, as well as the American College, would say interfacility transfers should be eliminated starting at some point that the TAC recommends to the state. And the EMS, we have to readdress timing because it's 45 minutes in the current plan, but maybe it needs to be longer. We chatted about that offline. So I'd appreciate Kate and Matt's opinion on that as well.
Thank you, Dr. Rappold. Brett?
Yeah, I may have misunderstood Rick or others in this conversation, but the idea of if you have a primary neurosurgical injury, that the local EMS provider should take that patient to the closest trauma center, I think is not the model in most of the state of Maine. I think that if you have a gunshot wound to the head in Caribou, they don't drive to Bangor, they go to the closest hospital. And I think CMMC certainly qualifies as a hospital that can stabilize and resuscitate those patients and perform a secondary transfer. So I think that we should maintain that model in terms of clarity and predictability and scalability of the system so that everybody is taking severely injured patients to the closest facility, and that facility can help determine whether or not the patient needs to go to a trauma center. So it's sort of back to my other, and others have said it too, my recommendation that we consider suspending the intrafacility transfer, but that every other major neurosurgical case in this primary service area should still go to CMMC.
Thank you, Brett. Dr. Scholl.
Yeah, thank you, Rick. And I think I tend to agree with Tom too, although I would offer that we're here not today just only to offer clarity to our EMS colleagues, but our partner hospitals and our hospital colleagues as well. And part of this deliberation today needs to be inclusive of the decisions that physicians are making about which facility to send patients to. And the other piece that I'll just offer is that it may be as easy as a gunshot wound to the head that defines a neurosurgical emergency, but it can be a lot more opaque, especially in the early phases of care as information is being collected in the midst of an EMS clinician. And I think, or for that matter, even in a transferring hospital, recognizing that our system has historically valued rapidity of transport over our system has commonly valued rapidity of transport over a extensive workup. And so we may not have all the information at the time that physicians are making some of those decisions, and therefore not be able to make those decisions and understand what the impact of those decisions are downstream. So number one, I do think this is important, not just to EMS, but to our hospital physician colleagues as well. I also think that it would be very helpful to have data available to help guide this conversation for us. And in the absence of data, right now, I think we are pressed to make a decision, and that might be that we can collect ourselves and with the assistance of data, make more informed decisions. But right now, without data to help guide us, I think we have to respond. And we have a trauma plan that fairly clearly lays out which hospitals can and cannot receive trauma transfers and what the qualifications are amongst the hospitals that can receive trauma transfers.
Thank you, Dr. Scholl. Julian Tango.
Thanks. I was going to say pretty much what Matt said, less eloquently, but it's going to be incredibly difficult to make any meaningful decisions for our EMS colleagues or our colleagues at outside facilities without some real meaningful data. I have specific questions about the 10% neurosurgery volume that was mentioned. Is that operative neurosurgery, consultative neurosurgery? It seems that proportion seems out of line with what we see here at Maine Medical Center in terms of our combined consultative services. So I just, without that, we're kind of working blind.
Thank you, Julie. Dr. Krupp, are you prepared to answer her question?
Yeah, I mean, I can answer the question. And I think part of this is the reason why I was a little concerned about a group this size because there are subtleties to this, as everybody has brought up. I mean, is it just a neurosurgeon clearing a spine on the way in, or is a neurosurgeon, actually having to decompress, a subdural or something along those lines? I'm not prepared at this point to be able to answer those questions. I think that it's important. I understand the importance, certainly from a volume standpoint. I do, and I can't figure out how to raise my hand. What I'm describing to this group is an interruption in our neurosurgical services. We are still certified by the American College of Surgeons as a level 2 trauma center. We do have a gap. I understand where that puts us as it relates to recertification, but the committee here, that's not the topic today. The topic today, as has been stated, is what do we do with neurosurgical patients? And as a group of providers here, given the volume of cases that are transported and the injuries and all the things that I've seen over the past few years here, I do think on some level we're not going to be able to come up with a final, but we're going to have to put forward an interim plan. This group will have to help our EMS providers to get people to the right place, recognizing that Central Maine Medical Center hasn't abdicated all of its trauma capabilities. We're still capable of making sure this state can function effectively with our given capacity, especially in current state. So I would tend to recommend, I understand the need for data. I think any decision on this side, this significance needs a group to be able to sit down with numbers and in a very thoughtful, deliberative way, which has been mentioned before, to be able to make some of these decisions. I would avoid, because I'm not ready to give the specifics that you're looking for. I would invite the committee to figure before we start invoking, the trauma rules and regulations, trying to figure out how we handle these neurosurgical issues in the short term.
Thank you, Dr. Rupp. I definitely appreciate that sentiment. I want to reassure you that we're totally here to help you and support the patients in the catchment area of CMMC. For that reason, I definitely strongly feel we're better off to at some point get into a very small group of folks who are very intimately involved in trauma care, trauma at the 3 trauma center level, maybe with a neurosurgeon or 2 that might also be impacted, and really dig into the data pretty heavily and figure out the best way to support each other through this. This isn't going to be easy on any of us, and I don't want to lose that and diminish that. So thank you.
Thank you, Julie. Dr. Scholl, is your hand up again or residual?
Oh, yeah, Rick, thank you for that. And I want to start off by really thanking Dr. Krupp for clarifying CMMC's interest in maintaining a footprint and an engagement around the trauma system. And I think that will undoubtedly be helpful for the state of Maine. I think the difficulty that I have and the difficulty that I feel from this committee standpoint is that we're talking about the system here and our current rules. And for that matter, the ACS would require neurosurgery to be present in order to be designated a level 2 trauma center. And our current rules note that neurosurgery is essential to be considered a regional trauma center. Our rules there also go on to acknowledge that only regional trauma centers can receive interfacility transports. And I think that is part of the dilemma we find ourselves in today in trying to adapt to and respond to this change. It's unfortunately for us, this loss is substantive in that it diminishes the trauma system and it changes, based on our current trauma plan, the stature of a single hospital in that regard. And I think we have to therefore wrestle with that today, and that's the purpose of this conversation. I do agree with Julie and with you that examining data is going to be very important in the near future so that we can look at what the impact of this is across the state as a whole and how this will play out. I am tremendously excited to hear a continued commitment to manage trauma at Central Maine Medical Center. I think that will serve the community and the state well, but we still on our end need to think about the plan and how this alters the plan and then communicate that with our colleague EMS clinicians and physicians across the state.
Thank you, Dr. Scholl. Dr. Tilney.
Hi, thank you. I straddle a variety of positions here, not only as an emergency physician here in Lewiston, but also a medical director for Lifelight. I did meet with Joanne and some EMS providers, EMS chiefs last week, and I think we are on to a discussion. We do, and I did reiterate, Central Maine is able to manage, trauma care. And when we first identified that there's a neurosurgical gap, we identified that there was no neurosurgery coverage. I immediately went off and informed that as an example, to the Lifelight staff, and identified that if there is a trauma that is a scene call, like someone was mentioning earlier, a head injury at Sunday River, that was probably best not served at this facility. And they would defer, and they've reached out several times to me as a medical director to say, hey, where do we go? And I've identified that already. But at the same time, when I was speaking with the regional EMS providers, again, if you had someone who has orthopedic trauma, and you needed to come to our facility to get stabilized, we can facilitate those, immediate scene calls, in Minot or in Turner or whatever it is, our local catchment area. And then we can stabilize. And if the onus falls on me as an emergency physician to transfer out, so be it. That does work. And we do that anyway, when we've had previous gaps in whatever coverage we've had, even in different specialties. So I think we continue to reiterate that and continue. I think that is the approach that we need to kind of facilitate from moving forward is, stabilize and then reassess. And if we have to, in our local catchment area. Thank you.
Thank you, Dr. Tilney. Dr. Rappold.
Sorry, had to hit the unmute button. Jason, I appreciate I ran the same problem you did. I don't want to put words in your mouth, but do you anticipate at some point restoring neurosurgical coverage to the trauma program at Central Maine, or is this a fait accompli?
Thank you for that question.
Yeah, I mean, I'm cognizant of this fact. It is very difficult to recruit neurosurgery to this community. Bottom line, I can tell you that we've been trying to recruit neurosurgery to this community for the 3 years that I've been here, and so it's difficult for me to comment on that because I could tell you, yeah, we're going to have it back in a month, but the truth is that we're a relatively small community. We offer very advanced services. So, I'm not prepared to, on behalf of Central Maine Healthcare, say it's a fait accompli, but I can tell you that it is, it's been incredibly difficult and we've been unsuccessful. And we've had a retirement of a neurosurgeon in the last 2 months as well. So, that's just the facts of the situation. So on behalf, we've not said that we're getting out of neurosurgery forever and ever, but I can tell you that I have nothing current, and I can tell you that it's just been incredibly difficult.
Thank you, Dr. Krupp. Dr. Rappold, are you set with that? Good, thank you. Chris Costello.
There. So I do understand that there are certain criteria that have to be met in order to fulfill the trauma center designation. I just, a couple things in my mind is, do we have, from the EMS provider's point of view, do we have any data on EMS services that bypass one hospital to go to the tertiary care centers for trauma? Because I don't think in Bar Harbor that happens that much, that they would go directly, to Eastern Maine. I think they would, go either to our hospital or to the hospital in Ellsworth first to stabilize first. So that's just one thing. And, I think from a small hospital's point of view, limiting then like who can accept transfers is really scary, scary to us. And I hate to kind of like just say, okay, it's black and white. And let's just, I think we need to really kind of talk this out a little bit more, especially because of the pandemic. I think we are experiencing a lot of challenges, and Sam was right. Like what was written about the trauma program certainly did not have anything into consideration regarding the pandemic. We have hospitals that are constantly kind of going on a rotating diversion, and EMS is kind of like having to navigate, okay, which hospital do I go to if this one's on diversion and that. So I do think there's a lot of value in what Dr. Tilney said about using online medical control to really guide the folks that are in the ambulances, to determine which facility is the best one if necessary. So just a couple of comments.
Thank you, Chris. I appreciate your input. Are there any other, Dr. Tilney?
Sorry, so, I see a note from Dr. Ritter in the box about, ground transfers. I think, and Dr. King and Tammy can put input of this. I think, we can manage our local area. I mean, I think that should not, my feeling is we should not be changing that. We had it yesterday, we had a GSW to the chest. We have good, capable trauma surgeons who are able to manage these. And we are able to facilitate, our local trauma. And I agree with Seth, the question is, we are still a resource for that. And I think that is, I don't see that changing. I said, if we had a United ambulance that's in town, that is across the street, I'm not going to send them to a different facility. That to me is a little bit crazy because we have a trauma surgeon who's standing here. But I think, if we have to transfer out for neurosurgical coverage, once we receive that person from, 200 yards away, absolutely. That is appropriate. But I think, and Dr. King will comment here, but the questions also revolve around, these transfers, coming to us, from other facilities. And that's where I think, and then, we still have a base here. We still have Lifelight that is, here and will remain here. One of the three bases for Lifelight. So we have to figure out that part as well. Thank you.
Thank you, Dr. Tilney. Dr. King.
Yeah, I want to just reiterate all that. I think the previous speaker, I think she's from Bar Harbor, really laid it out in clarity for the smaller hospitals. Again, just like Director Hurley said at the outset, these rules were not written during a time of a pandemic. And to Dr. Scholl's point, yes, we have rules that we have to follow, but we still have a crisis in the state regarding capacity, which almost borders on capability. So if we're able, there are two questions that we have to decide, I think, as a group. One is, do we continue to accept and support the trauma mission of the state, which is non-neurosurgical? And also, what do we do for clarity for neurosurgical cases that are obvious for the EMS system? But I think those are two separate issues. And I think we really need to provide clarity for both of those.
Thank you, Dr. King. Dr. Krupp, one question for my clarification. Based on, I want to make sure I understood you correctly. It would be Central Maine Medical Center's intention to continue to admit or treat and admit non-neurosurgical patients that came to you by ground 911. Is that correct?
That's correct. We feel we have the capability, same as we had last week, and we have the infrastructure to do it. So yes, that's correct.
Great. Thank you, Dr. Krupp. Director Hurley.
So kind of surmising what we've been talking about, at least in my vantage point, it sounds as though the next step here is to look at what we have, look at the system, look at capacity. While yes, Dr. Krupp, I realize that you still retain the plaque that says accredited level 2 trauma center. You don't have capacity 24/7 for neurosurgical capability. Done. That's my conversation. EMS can't call you every time and ask, hey, do you have a neurosurgeon, to decide whether or not we're going to bring you a patient. That's not practical. So that's kind of our stance when it comes to designation or not. That's the concern, is the capacity is not there 24/7 as it would have been previously. I think the plan is fairly clear. I think at this point, we need to discontinue transfers to this facility. There should be 911 services should still go to this facility for trauma patients. It doesn't make sense to stop trauma transports to this facility if they reside in the trauma catchment area. I think there may be a conversation about us adjusting the trauma catchment area, the number. We usually use a 45-minute window. I think we may need to consider what does an hour window look like, because I don't want to take and dump, as we saw say in EMS, I don't want to dump a neurosurgery patient at Central Maine because our protocol says it's greater than 45 minutes away, so don't go to Maine Med. I don't want to dump on Central Maine because that puts Central Maine at risk, and it puts the patient's life at risk because they're going to have to go to Central Maine, be stabilized, be assessed, then transferred, and we all know that transfers don't happen quick right now, or if they do, it's tough. It's tough. A quick transfer may be an hour, when we could drive 30 more minutes and be at a facility. So that's my concern as to where we are. I think it would be foolish for us to say that Central Maine can't receive traumas. I think that is foolish. But I think the reality is that we need to make sure that EMS clinicians know that if you have something that you suspect cranial involvement, or you suspect brain involvement, or you expect spinal involvement, they likely should be diverted. If you're within the hour or 45-minute window, they should be diverted to another facility, and that all other trauma, like regular penetrating trauma, blunt trauma, that doesn't impact those organ systems, the neuro system, should be taken to Central Maine because they have those capabilities available. And, we shouldn't cut our legs out from underneath us, and, take away that resource that's there and, ready to operate. Because the reality is if we take that away, then Dr. King's not going to be funded. I mean, if we take away those resources, that's how they fund Dr. King and others. So, I don't want to take that out from underneath them as well to support the system going forward into the future. So I think we kind of lean in on our plan and follow our plan. Our plan says no more interfacility transports to this facility based on the way it's defined. Those would go to level 1 and level 2 centers. It could be a conversation that's had at those centers if there may be something that could be transferred, like I think a simple hip fracture from a ground level fall. But those are conversations to be had in granularity with the trauma receiving physicians at other centers to, Dr. Reppel to say, hey, we are slammed right now. I think this case would be acceptable at a level 3 if they have capacity. I don't know if that's an option, but I'm just trying to, how do we capitalize on the resources that are available at Central Maine without putting the risk of sending something there that ends up having to be transferred again, or we don't want to do that to the patient. We're just trying to protect the patient in the end. So those are my thoughts. That's where I am right now.
Thank you, Director Hurley. Dr. Scholl.
Yeah, I would support that, in particular the parts that continue to affirm the role that Central Maine can have in trauma and continue to utilize Central Maine's role around the trauma system, especially in those ground-based 911 transports that would be going to them. I think if we, as Director Hurley mentions, lean into our current trauma plan, there's still a large catchment area of patients that Central Maine would be could be the primary trauma center for, rather than bypassing them. And I think we do need to recognize their not just historic stature and engagement in the trauma center system, but also their capabilities, which are admittedly far more advanced than some of our other trauma systems, not all, but some of our other trauma system hospitals. And so this idea of maintaining the current trauma triage guideline, Central Maine receiving those patients primarily within their catchment area, but then following the remainder of the trauma plan as it's laid out makes sense.
Thank you, Dr. Scholl.
Rick, can I comment?
Yeah, oh, absolutely.
Sorry,
Yes.
I don't have a hand to raise on my screen, so I'm not sure how to get your attention.
I think it's a Central Maine thing, Dr. Krupp.
It could be just
because Tammy's having the same problem. So
I know how you keep me quiet. Just don't give me a hand to raise. Yeah, I mean, I am not in disagreement with what I just heard. I mean, I think some of this is a, you know, as I described before, a bigger conversation about the you know, how the trauma system in Maine adapts to changing capabilities. I would like to, you know, if in hearing about the inter-facility transfer issue, I heard from Dr. Hurley that you know, that there could be leeway for a transferring facility for neuro-related transfers to be able to have a conversation, i.e., you know, there's a low, you know, somebody falls out of a bed and breaks their hip, and we have the capability of handling that with 24/7 orthopedics, and could take that patient. I know that's a bigger conversation. The only other thing that I would like to bring up, if we're talking about interfacility transfers, is our own hospitals, Rumford and Bridgeton, being able to have the same capabilities that I understand Maine General has with regards to accepting patients from their own system. That's something I would ask the committee to consider, given that we are one system. And you know, the other piece, of course, is well, I'll stop there. So I mean, that's what I heard. Tell me if I'm off, but you know, besides that, it sounds like we're moving in a constructive direction.
thank you, Dr. Krupp. And I do want to confirm Dr. Krupp's opinion about the interfacility transports of patients within the same system. This committee did in fact approve Maine General Medical Center's request to be able to receive transfers from within their own hospital system a little while ago. So so thank you for that. Tammy LaChance, I believe you had a question as well.
I was actually going to ask the question about elderly same level fall hip fractures being interfacility transfers from other facilities, and if maybe we could exclude that from the no receiving transfers rules in the trauma system plan, if maybe we could edit that to exclude that population of patients who have isolated hip fractures from low mechanism same level falls.
Thank you, Tammy. Do we have any thoughts about that from the group, about Tammy's request?
Yeah, Rick, I certainly would echo that. And it may not just be for isolated elderly hip fractures. It might be for single system orthopedics, you know, absent mechanism. Again, though, I think that this is something that can be deliberated more carefully in a longer meeting. Unfortunately, I think we're overdue already. So again, if we can extend the meeting and create a motion that includes that, I'm all for it, but I'm not sure how long you want to extend past the agenda time.
I think the agenda was put forth based on pure speculation about the level of discussion, Pratt. So I'm okay for us to go a little bit further. Julie, did you have something for the group?
I just wanted to expand upon Tammy's comment about isolated hip fractures. There are some particular exclusions within the regulations regarding those being registry eligible. So those might be an interesting cohort to sort of break out and look at separately, because they may, in some cases, not even be qualifying as trauma patients and probably are a relatively high volume population. So as a subgroup or whatever, that might be something that we want to take up very specifically.
Thank you, Tim. Thank you, Julie. I appreciate it. Tom Judge.
Yeah, I think following that, I'd still like to go back to the clarity for EMS providers. And I think that I've not heard anything different that trauma patients, the general trauma patient, especially needing life-saving intervention, should go to the closest hospital. That's practice, and I think we ought to reaffirm that. I think there's still, on the clarity for EMS providers, the idea that single system neurotrauma probably ought to go to the closest regional trauma center as quickly as it can. That may involve a stop at a trauma system hospital, and that may not. And the providers, I think, make good choices around that. I think the multi-trauma patient with altered mental status, the uncertain patient, does this patient have a concurrent head injury that we don't know, as Matt described, as like we're still getting data. Maybe that patient should be similar to the single system neuro, go to the regional trauma center with neuro capabilities by the fastest route possible. And then personally, I'd like to see maybe us hold on this. We could get into a lot of weeds on the detail of the transfers. It sounded like Central Maine had more discussion internally going on and more data. And maybe we could create a smaller group with attack, because I think this does get into the longer term questions of what are the capacities and capabilities of all our trauma hospitals. And so to start singling things out, we'll do this, we won't do this. My sense is that should probably be part of a wider discussion, and maybe we should hold off on making any other decision about transfers and give that to a subgroup and to come back and maybe within a certain amount of time, and that would allow Central Maine to finish whatever internal discussions they have and share that data with the Trauma Advisory Committee.
Thank you, Tom. Dr. King.
So I just want to ask actually a question for the committee. The previous speaker from the small hospital still resonates with me, because that's what we need to provide clarity for our small hospitals that are calling around. And we all know that that's been going on. In absence of a coordinated military type, and I know Dr. Rappold understands this, having been a combat military surgeon, that the coordination of care in the military is excellent and should be really mirrored at a state level. But Joe and I have been in constant conversation about what our capacities are and what we could accept. I was just wanting to ask the committee that if, say, a small hospital in Bar Harbor calls Maine Medical Center or Bangor, and they just have no capability or capacity, that we are still able to accept interfacility transfers on a case-by-case basis and conversation. Can we say that for all of the hospitals that might be listening on this?
What are the thoughts of the group? Dr. King's request.
Again, I would just reflect on the patterns that exist for other community hospitals. And if Eastern Maine were to receive a call and requesting a neurosurgeon or a orthopedic surgeon or any other specialty surgeon, they would be directed to a trauma surgeon most of the time, who would help to sort of negotiate whether or not that patient needed to be transferred immediately to a trauma center or to be staged and transferred after overnight, and you have better resources, or if they need to go to another hospital. It isn't the practice of level 1 or level 2 trauma centers to refuse major trauma, but we do negotiate for single system stuff all the time to delay their transfer, stage their transfers, or to refer to other partner hospitals. And the system needs to be able to do that. But I think in terms of acute emergency decision making, the system that works for other community hospitals in the state has worked well for generations, and basically dictates that the patient goes to the closest hospital for evaluation, and that hospital refers to the nearest state regional trauma center for further advice and disposition of that patient. And I think we've been able to do that. I regret that we'll be missing one of those resources. I regret that there won't be people at CMFC, if that proposal flies, that will be able to help us triage. But it's important that, especially in terms of neurosurgery, that those patients don't get missed and sent to a facility that can't intervene and needs to do a secondary transfer and amputate that EMS crew from its community, and confuse and delay care of a critically ill patient.
Thank you, Brett. Director Hurley.
So I agree with Brett on this. I think that as I was mentioning before, I think the level 1 and level 2 trauma centers should be the receiving facilities for all interfacility transports. If the receiving physician feels as though that patient could be transferred to Central Maine or another facility, then they can offer that option. But the regional trauma center should be taking the first swipe at it. And they should be triaging these patients. That's how our trauma plan is written. And I think that it still doesn't eliminate the possibility of IFTs going to Central Maine Medical Center. It doesn't force IFTs to Central Maine Medical Center, but it also gives our system capacity to do that, should our level 1 and level 2 feel as though it's appropriate for Central Maine to be handling. But we also can't make it where Central Maine, no offense, and not saying that anyone would ever do this, but we can't enable Central Maine to cherry pick, oh, I want to take all of the hip fractures this week. I mean, because that's essentially what we would enable them to do. No one's going to do that. Not saying anyone's going to do that, but I'm not sure that's how our system is designed or should be built. And so I think the right way to go forward is to adopt a system where they can no longer receive direct IFTs. It has to go through a level 1 or level 2. Should the receiving physician at a level 1, level 2 feel as though that it's isolated trauma and could be directed to Central Maine Medical Center, they defer and refer them to Central Maine Medical Center for evaluation, treatment, and care. And I think that way we follow our trauma plan as written, but we also give a pressure valve to make sure that we keep them in the system and keep them actively participating. But I don't think that we can, because otherwise we need to ask Maine General, we need to ask all of these other hospitals if they want to start accepting hip fractures too, if they have orthopedics on duty. But, I just think we have to be equitable here. And I know Central Maine has more resources than many facilities in the state, and I'm not denying that. I just think we have to look at it. We have to take a step back, look at it from behind the curtain and say, what do the numbers show? As far as, you have this, this, or this, or you don't have this, this, or this.
Thank you, Director Hurley. Sorry. Dr. Bowie.
Thank you. So for those of you who don't know me, I'm the Chief Medical Officer here at Midcoast. I'm an emergency physician and have been in Maine for some time. I am new to the Trauma Advisory Committee, however, and I guess I have a key question that I'm ruminating on in this discussion, and that's the point of transfer. So if we're transferring a patient who is undifferentiated, so for example, here at Midcoast, a patient who comes in with a multi-system trauma and comes here because we're the nearest place and they need immediate care, they need an airway established, I consider that an undifferentiated trauma patient who I think needs to go to a trauma center. And I think that's what we're guiding here. Now, if we have a trauma patient who comes here, fall off a ladder, we image their head to toe with a CT scanner, we identify all their injuries. I feel that that's a different transfer, because now I need to find someone who can take care of a specific injury, and I have the injuries defined. And I'm curious, is that a differentiation that others apply, or do we not apply that? Because I think if we apply it that way, I have an entire explanation of what injuries this person has. Then I would need to find a facility that can care for them if I can't care for them. And then Maine General, Central Maine Medical Center, any place that can provide the care and has an available bed seems as an appropriate place to send that patient. The undifferentiated trauma patient who I'm making efforts to stabilize and send, that patient I think needs to go to a trauma center. But again, I'm new, and perhaps that's not how it's considered, but that's my question for the group.
Thank you, Dr. Bowie. Dr. Krupp, go ahead, and then I'll see if anybody has an answer for Dr. Bowie.
Oh, yeah, I was just, I found the raise the hand button. Thanks, Dr. Ritter. You know, I understand what Director Hurley was saying. You know, of course, in the same way, it's unlikely that we would sit there and say, hey, we just want hip fractures this week. You know, again, if anything that came to us through interfacility transfer under the current system had to go through another system first, I mean, isn't it just as likely that that system would sit there and say, hey, we want this one, we don't want that one? Which, you know, again, that's not the purpose of this committee. The purpose of this committee, as I understand it, is to be collaborative, collegial, and support the patients in the state. You know, I think that at the end of the day, you know, this concept of you know, this is, again, going back to why I think that this really does, some piece of this, and we've already started getting into this discussion, is going to require a more deliberative look at how do we utilize the resources of the state in the best fashion possible. So I just wanted to throw that out there. So apologize. Chris,
Great,
good to
thank
see you. Answer your question.
Yeah, thank you, Dr. Krupp. I really appreciate it. Does anybody have any thoughts about Dr. Bowie's question? Dr. Scholl.
Thank you, Rick. And Chris, thank you for your question. And I appreciate your perspective as a new member to this group. That's very, it's actually very nice to have you here. You know, I think your impression, your question, it makes a lot of intuitive sense. However, this group has historically argued against that exact rationale in the past when we have encountered other similar circumstances with other hospitals that were entertaining the possibility of level 3 status. And I'd have to remind myself of the entire sum gain of that. However, one of the issues has been that while in some cases you're absolutely right that we have historically, again, valued the rapidity of transport over the depth of the workup, in some cases, there can be partial workups or incomplete workups, even in the situation that you described, which have led to the need for neurosurgical resources, et cetera, in the past. And I think that probably was part of what drove some of those decisions from this group in the past when we had similar conversations around other hospitals that were willing to, interested, and able to step up those level 3 trauma systems. I think that still becomes a really important question, though. And I think as we evolve as a state, as we evolve as a trauma system, we need to bump into the question that you ask today. I don't know that we can come up with a definitive answer to that today, though. And I think, you know, one of the reasons I'm interested in data and looking at this is that I think we could get to the answers there. And I maybe perhaps in light of not having the available information to make informed decisions, we end up maybe making an interim decision today and then coming back or having a small group opine about this and think out loud with us over a longer period of time that allows us to make a more informed decision based on the information we have available through collaboration and dialogue amongst the trauma system hospitals and trauma centers as well. That's my thought about this. And I agree. I think in some ways, we have to take a step back. Our current plan is laid out as such. That current plan made a lot of sense in the past system. Our system has evolved and our plan has not kept up with it. I think perhaps we might find ourselves following the plan for now, engaging in larger, deeper conversations that are informed by information and data and making more informed decisions in the future.
Thank you, Dr. Scholl. We've been having this discussion now for just about an hour and a half. Is anybody, does the group feel comfortable at this point, based on the discussions, making a recommendation of the plan that we would recommend to the Maine EMS board? Dr. Rappold.
Go back to Jason, and I'm more convinced than ever that we really ought to sit with the data and make some really specific determinations. When would we be able to see that data, Jason? With you?
Yeah, as I'm, obviously as I have no standing with this committee, and I will, how do I answer this? I think by next week I'll be able to sit down with members of this group as appropriate, to go through our trauma numbers, to be able to look at volumes, because I presume that in the discussion on the data and what to do about it, this is really, unless somebody can tell me differently, this is really looking at, okay, how many patients are we actually talking about are going to be affected? Is that essentially, do I have that correct, from the committee standpoint?
I think Jason, we'd like to know your total number of trauma admissions, how many are interfacility transfers, your ISS is greater than 15, how many go to ICUs. I mean, we need granularity to build the system around you and help support you,
okay,
and Central Maine staying afloat.
Yeah, let's plan to sit down next week. I can, through the members on this committee with Joanne and Pete and Richard and Tammy, who are our representatives to this committee, I will make sure that we reach out. Rick or Dr. Rappold, do you all want to give me a couple of folks who want to sit down with us, and we can go from there?
I certainly think that's a good idea. A handful. I think it'd probably be up to Kate and Matt to decide who they want to see sit with you and via Zoom. And then I think we need to bring this committee right back to business. And I mean, next week's a tough week, but I think if we could do it early in the week and follow it right up with an emergency meeting.
I was thinking Christmas Day. If you all are dedicated enough.
I'm
Christmas
Jewish.
Day.
I don't care.
Dr. Rappold, just in the interest of clarity, are you making that a motion that that we convene a small group to gather the data?
Well,
from
I
Dr.
mean,
Krupp?
we probably could have avoided the 90-minute discussion if that's what I had said an hour and a half ago. But I think as the discussion has played out, I think data and what Tom and Sam and Matt have said probably are warrants that exact process. But I also think if we did something Monday or Tuesday, we ought to meet the following day with this committee again and make some decisions. Is that something you would support, Sam?
I'm supportive of the idea of having a subcommittee to hone in what our plan is going forward, and we absolutely have to see the data. But I do think we need to be very specific to our EMS clinicians today, what our guidance is today. And I think our guidance is go to the closest facility that can manage the patient at the time. If it's Central Maine Medical Center is where you're closest to, that's where you need to go. And I think we also should have the recommendation that, should they suspect any neurological or any neuro involvement, that those patients should be going, we should be trying to bypass and going to you or to Bangor. I just want to make sure that EMS is abundantly clear. And I think for interfacility transport, we need to be clear to our hospital colleagues that this facility doesn't have this capacity right now. And I'm not saying that the facility would ever tell someone that they do and, you know, even accept a patient like that. But I think we need to be very clear. I just don't want there to be ambiguity in the interim as we wait.
Thank you, Director Hurley. Dr. Reppold, I'll come back to you. You seem to be leaning towards making a motion. Do you want to do that, or do you want to?
So the motion, Rick, would be a small committee determined by Kate and yourself of who they want on it to meet with Jason and Richard and Tammy in very short order, followed immediately by another emergency meeting of the attack.
Thank you, Dr. Reppold. I know there are a number of their hands up, but before we discuss this, we would need to see if anybody was willing to second that motion.
Joe, I would second that motion under one condition, if you would allow a friendly amendment, and that is that we affirm the position of the trauma plan to halt interfacility transports until this group can make a recommendation to the TAC and then the board, in order to ensure that we're consistently finding patients are consistently arriving at the most appropriate place.
I concur.
So we have a motion from Dr. Rappold with a friendly amendment.
I'll second.
I think, Brett, we already had Dr. Scholl seconded with the friendly amendment. Thank you, though. The motion is to convene a small group to review the data with Dr. Krupp, Central Maine Medical Center, and then follow it up with another meeting of this group to discuss the data and the plan moving forward, but also in the interim to immediately implement the trauma plan as it stands right now as far as interfacility transfers go. That's the motion and a second.
Rick, do I have any standing? It's Jason. Do I have any standing to discuss? I see Director Hurley saying no, so I will be quiet.
Thank you, Dr. Krupp. Bill Monteo, blast from the past. Nice to see you. Actually, you know what, Bill, I got to stand off for a second. I apologize. I was so excited to see you. I do not believe actually that you're a member of the TAC, and we're not entertaining public comments at this point. Do any of the TAC members have any comments or further discussion about the motion?
This is Amy. I don't know how to raise my hand. Can I say something?
Sure, Amy.
Sorry. I know someone posted on how to raise their hand and I can't find it. My concern is the interfacility transfers and what that will do to the system. I think there are some things that CMMC should still be able to cover, and there are some things they can't, obviously, with this lack of neurosurgical coverage, but I don't think that no transfer should be able to be done at Central Maine.
Thank you, Dr. Fenwick. Tom Judge.
Yeah, I would just like to see us make these decisions with data. So I think earlier I'd said, here are the EMS patients that ought to probably go direct to regional trauma center with neuro. That's the EMS clinicians that we need the MDPB to offer immediate guidance to. I'd like to see us hold on making any other discussion if we can do this data and very quickly, but making a decision today that we may undo a week from now doesn't make any sense to me. I think we ought to make decisions with data. I don't think there's an emergency to suddenly change how things work. It's very clear no neurosurgical patients are going to go to CMMC in the interim. I'm just not convinced of why we need to to make any kind of other distinguishing things to people until we have the data. I would rather see us work with data.
Thank you, Tom. Tammy?
Hi, I was going to say that what Tom just said, that I agree. I think we need data in order to be able to decide who should come for interfacility transfer, just where beds are so limited in the state right now. And we're really trying to keep patients as close to their families as possible. You know, the more that we say no, the further that our patients in our community are going to have to go from their families. And I think we need to try to keep them here as much as possible. So if we can get the data and talk about it very soon, I think that's a better thing to do. Another thing to consider is just how hard it is to turn off these messages once we turn them on. You know, once we tell EMS or hospitals not to do something, it's hard to change that. So I think, you know, before we make any new rules, we ought to, you know, really have some good data before we make them. That's all.
Thank you, Tammy. Dr. King?
Yeah, I agree. I just want to, second that, because there are two separate issues, and I think, Dr. Bowie had brought that up. There's one about, the obvious multi-system trauma that needs to go to a trauma center, but then there's also the issue of the capacity of the hospitals. And if we make a decision about those two separately, or at least if we bring those two together, I think we're going to do a disservice to the people in the state, because these small hospitals are desperate. We all know that. I mean, Joe and I have conversations about this where he's saying, even before this all happened, do you have to send this patient? So let's not forget that. Let's not just throw the baby out with the bathwater, so to speak, and then revisit this.
Thank you, Dr. King. Dr. Bowie?
I guess I'm a little confused, because I feel that the motion Joe made and Matt seconded is that we're following our current rules and then getting data to decide if we're going to adjust things. And then an argument made against it is we should wait for data, but we should not follow our current rules. And if our current rules right now say we should not be sending transfers to CMMC when they're not meeting the designation to accept them, it seems as though we're all sort of stating the same thing. We should follow our current rules until we have data to suggest we adjust. And I think that that's what Joe and Matt have suggested with this motion.
I think, yeah, Chris, I think you're spot on. I think we need to, I don't know how we change motions, but until Jason and the smaller group can get together with Richard and Tammy, so we can make some understanding of what we're talking about, the implications. And I agree with Tom. I mean, we shouldn't change in a week what we're going to decide. What we decide today, we shouldn't have to go back and change it again in a week. That's not what our EMS providers need or want.
Okay.
Can we just put this whole thing on abeyance until middle of next week, until we meet with Jason, Richard, Tammy, and the small committee that's set up by you and Matt and Kate, and then followed immediately by another emergency meeting of the TAC, and then let operations go as operations are going. I don't know. I mean, you guys are the experts.
That would require you to change your motion and see whether Dr. Scholl agrees with that as a second. So do you want to change your motion to put the whole thing on hold until the small committee
I mean,
meets?
if we can do it short term in a week, and I think I got the impression from Jason, he can support that in the next couple of days, then I think we should do that. I would suspect Matt would support it for a couple of days.
Okay, so if I understand correctly, you're wishing to change your motion to table the discussion until the small group meets to discuss the data, followed by another immediate meeting of this group.
Yes.
To review that. Is that correct?
Yes.
Dr. Scholl, how do you feel about that?
maybe I'm the only one who feels a sense of urgency in messaging right now. And granted, I know how complex messaging is because we do it quite frequently within the Maine EMS system. But what I think is left before us is that we have a current plan that has a current course of action for this such position. And that current course of action and the steps that are laid out are fairly clear within that plan. Now, as I mentioned in the context of supporting Joe's motion, I am fine with taking steps to deliberate with data and more conversation. However, I feel a sense of urgency to make a statement now, and our plan tells us what that statement should be. And I kind of feel like we have to come out of this meeting with a resolution for EMS and for our colleague hospitals. And there's a discrepancy right now between what we're saying we're going to do and what our plan says we're going to do. And so I feel a little that's a hard discrepancy to reconcile. I also I was hoping, based on conversations prior to this, that we would have been presented with some of this information so that we could have this conversation and have a full conversation. And so it's hard to not have available information to make this decisions, but I feel like we need to come out of this with a decision about what we're going to do. And our current plan does lay out what we're supposed to do. So I feel unsettled with altering this motion.
Thank you, Dr. Scholl. So Dr. Rappel has expressed an interest in altering his motion. You are not willing, appear not to be willing to second that. So is there anybody out there who's willing to second Dr. Rappel's motion?
Point of order, you need to vote on the motion that stands on the table, as it's not, they haven't been willing to change it. So you have to vote on the motion on the table. Okay.
Sam, you and I have both also come into information from the state that I feel may be relevant to this discussion. That the concern from the state licensing board is that not allowing Central Maine to accept transfers put them at risk for EMTALA violations if they don't accept patients that they're qualified to treat. Is that an appropriate summary of that statement?
I think we would need to hear from Mr. Monteo directly, and I would recommend that we open up comment to Mr. Monteo at this time, because he may have something that's particularly salient to this vote.
Okay. Do we, can we do that in the middle of the motion where it's relevant to it? Do we need a motion to accept it?
You're gonna have to vote on what you're doing, and then you're gonna have to make another motion to open it up to him. That's based on Robert's rules. That's how you would do that.
Does Dr. Rappold have the ability to withdraw his motion pending?
He could withdraw the motion, and Dr. Scholl could withdraw his second, thereby taking it off the table.
I withdraw the motion.
Sure.
In the interest of conversation, I will withdraw the second.
Thank you. All right. The chair recognizes Bill Monteo from the state of Maine. I'll actually let Bill tell us where he's from, but he may have relevant information for this conversation. Bill?
Thank you, Mr. Petrie. I just want to make the committee aware of the federal regulations under EMTALA. I did put the regulation in the chat for your reference and review, and while you're contemplating this, because I know it's not the intention of the TAC to create unintended consequences, as the regulations don't specify designations and when it comes to trauma facilities, but they do under 42 CFR 4924 indicate that when there's a transfer, and I know there was some discussion about the trauma plan, and when there's a transfer, a receiving hospital that has specialty capabilities, that has the capabilities and the capacity, must accept a patient that needs those capabilities and capacities from a sending facility that does not. And the kind of the classic example that I would give is a rural hospital that lacks orthopedics physicians that has a fractured hip, and I've heard that reference before. If the facility, in this case Central Maine, has orthopedic surgeons, has open beds and capability and capacity, they cannot refuse that transfer. So I just want the committee aware of this, that as you're looking at discussions of your trauma plan, without some really specificity in it, you may be inadvertently opening the hospital up to EMTALA violations.
Thank you, Bill. I appreciate you bringing that to our attention. I think that's an important piece of information.
Just
Julie,
wanted you to have the information, that's all.
No, I appreciate that. Julie, did you have a comment?
I forgot my hand was up, but my specific question was, do we know when we can get this data? In order for me to really decide how long we would wait or not, I do feel like there's an extreme sense of urgency in this. If the data were available tomorrow, it's very different than if it's available next week or the week going into Christmas or the week after Christmas. So what's the timing of concrete data availability?
I think that he had indicated that the data would be available in the next couple of days. Dr. Krupp, is that correct?
Yeah, I mean, the data will be available in the next couple of days, but to be perfectly frank, I mean, I would like to sit down with a small group and go through this. I don't think, throwing the numbers in a group with, with the audience that we have is the appropriate way to look at data and discuss consequences and actions, in my opinion. So, I mean, I will have the data available in short order. And, as we discussed before, Rick, whoever we'd like to sit down with and go through this, happy to do it in short order, as I said.
Thank you, Dr. Krupp. Director Hurley.
One thing to note, I appreciate that, Dr. Krupp, but unfortunately, that will not be possible. We may have a small committee, but it will have to be a public meeting, as this is a public, statutorily defined board. So it will have to be a public meeting.
That's fine, but then I would suggest, Sam, that I think we need everybody's data. I think we need to sit down with all data and discuss the system in total. I just, I think if we're looking to serve the state as well as possible, if that's the charge of this committee with regards to how we care for trauma patients in the state, then I would suggest, if it's going to be a public committee, then we all sit down with our data. So obviously I don't have that capability of recommending that, but that would be my stance.
I didn't raise my hand yet, but Jason, I don't understand. I'm sorry, Rick. Jason, I don't understand the need. I mean, we're happy to provide our data to anybody, anytime, anywhere. And I would imagine Pred and Amy are of similar thinking. I don't know what that gets. I mean, the issue on the table is a neurosurgical gap in coverage. And we're just trying to prepare for what potentially is coming our way in terms of resources needed to support that added workload. I'm missing what you're trying to achieve by saying having all the data on the table.
Oh, no, I appreciate that, Joe. And I think that, I think you've been very forthcoming. To be fair, we learned about this committee meeting through the press 24 hours ago. And, I don't feel compelled. I want to get to the same endpoint that you do for the system. I mean, this is not ideal. We're trying to find a way through it. I've expressed to you that I'm absolutely willing to sit down with a small group. What this group chooses to do with it, Director Hurley, from a public standpoint, that's your prerogative. But in terms of being able to sit down with our information and discuss with the select group first, I think that that's not an unreasonable request.
Thank you, Dr. Rappold, Dr. Krupp. Dr. King.
Yeah, I just again want to reiterate, there are two separate issues here. There's one, yes, what we need to do for the neurosurgical patient. We need that data. I completely agree. But at the same time, there's also a discussion about what that effectively means for what we do, level 2 versus level 3. And I think where the data becomes important is to look at exactly what the capacity of Maine Medical Center and Bangor have in order to accommodate the Mid-Coast, the Bar Harbors, so that, you know, the people of the state, the people of this committee know whether or not we really truly need a level 3 designation and we can still accept trauma. Again, we are a fully capable trauma center minus neurosurgical capability. And I realize we cannot answer that question now, but we have to separate those two out. So the data for all of our trauma centers would be useful, not just simply to answer the neurosurgical piece, but also going forward, what can we do to help this state out at a point of pandemic and staffing crisis? Let's not forget where we are. So I'd like to, you know, maybe have that as discussion at a later meeting, or maybe see how we can actually incorporate that into a later meeting.
Thank you, Dr. King. Dr. Fenwick.
Yes, so two questions. One, is there a way that we can meet independently and not have this a public meeting, just a TAC? Or is TAC automatically public? And the second one, I do think it's helpful to have the data just to prepare in the sense of shortage of all the hospitals that we have and for staffing. I don't know how much of an impact it might make, because I believe we're all very short of providers on all levels, but I think this can help prepare us a bit for what may be coming.
Thank you, Dr. Fenwick. We are, Trauma Advisory Committee is in fact a subcommittee of the Board of EMS, and all of our meetings are public meetings because of that. Julie Untango.
I was going to say something similar. You know, the three trauma centers have a long history of working together very collaboratively outside of TAC. We've been meeting every other week to talk about the challenges and you know, share information that can be helpful to each other and support of each other. Is it possible that the three of us get together in the next 24 hours and really talk about the numbers outside of the TAC? And I don't know if that's allowed or not, but we have to be very candid with each other to support each other and to support the patients of the state. I today believe in the trauma plan as written, but I want to be a good steward of our resources. I want to support the people of Central Maine. I want to not burden other hospitals while they're struggling as well, but I want to make those decisions in a very pragmatic way. And I think that we have the right people here within our trauma centers to be able to really get down to some the details that could be brought back to this group if that didn't violate any principles. I understand the sensitivities of it, and I'd like to be part of a solution with that, and I'd like to be supportive, but get there expeditiously, because I do believe this is extremely urgent.
I'm happy to do that as well. Thank you, Julie.
Thank you, Julie. Dr. Scholl.
You know, as I kind of consider this whole circumstance we find ourselves in, the thing that I'm sort of left with is that I too feel a sense of urgency that Julie mentioned. I think others have mentioned that as well. What's challenging for me personally is that we have a significant change in our trauma system, and that one of our level 2 trauma centers is effectively operating as a level 3 right now. And as a state, we don't have a lot of precedent with level 3 trauma centers. And listen, I am very appreciative of the continued commitment to trauma that Dr. Krupp, Dr. King, Tammy, others have alluded to, because I think our future trauma system is going to heavily rely on them and perhaps other hospitals that want to stand up level 3 capabilities. But I just don't know that we as a state have ever had a plan that introduces level 3 centers. And we have a very, very binary plan right now that rests on both regional trauma centers and on trauma system hospitals. And what feels imperative right now for us to acknowledge is that we don't have 3 regional trauma hospitals, and it feels like we need to make some changes today. And then as we have more time, as we deliberate more about this, as we as a state consider what to do about this, as we consider the roles, responsibilities, capabilities of hospitals that want to introduce level 3 verification in the community, I think we'll have a lot more clarity on what that means and how to use those facilities. But at this very moment, I don't know that we as a TAC have that experience. We certainly don't have precedent. And in prior times when this body has adjudicated those types of facilities, we have reaffirmed our current trauma plan and the actions of our current trauma plan. And so I guess I feel that sense of urgency, and I feel that sense of change that has occurred. I feel it important for us to act today, and then certainly affirm the importance of reviewing data, reviewing experience, collaborating together, really working on the same values and that we've exhibited in the past around collegiality and cooperation. But I feel like if we don't do something, we are putting our system is in jeopardy, because we never have had a level 3 functioning in this capacity.
Thank you, Dr. Scholl. Tom Judge.
Yeah, maybe to try and help move this along, make another motion. We'll see if someone wants a second. I think it's sort of 3 parts what I hear. One is I think the MDB has to issue clear guidance to the EMS clinicians about what to do with single system neuro, multiple, undifferentiated trauma with altered mental status, and those patients that need life-saving intervention. And I think that can be immediate. We talked about that as the immediate need for EMS clinicians to do something. I think the MDB, I think Matt could work with his colleagues and get that done very quickly. Secondly, I think that it's very clear to say, and Central Maine has already agreed, that no neurotrauma is going to arrive at Central Maine on an interfacility basis, right? So we can say that, and I think that's, there's no discussion around that. The third piece is that I think, and I think Matt's correct, I think there is, I'm not sure that how urgent this is, but it's not something that can be put off forever. So I would like to see it if the 3 trauma centers can work together and come up with their own recommendation to a small committee of the trauma or this committee, and then within 2 weeks to make a recommendation on the larger issues around interfacility transfer. So do it in a reasonably urgent fashion, recognizing the holidays, recognizing the pandemic, and hopefully the 3 trauma centers could work together to have a collaborative recommendation to the TAC to take forward. So a 3-part motion. 1, MDPB issue guidance to EMS clinicians. 2, we're saying no neurotrauma interfacility to Central Maine. I think everyone's agreed with that. And the third is to get the data and make decisions about what the trauma system ought to look like based on data. And I would certainly be hopeful that the 3 trauma centers could work collectively to come up with some recommendation to this committee to then discuss.
Thank you, Tom. Is there anybody out there who is willing to second Tom's motion? Dr. Fenwick, I can't tell what you're doing.
That's a second.
That's a second. Thank you.
Because otherwise it's a hand that gets withdrawn.
Thank you, Dr. Fenwick. We have a motion on the table from Tom Judge, a second from Dr. Fenwick for a 3-part motion made by Tom Judge. Is there any discussion about Tom's motion? Okay, not seeing any. I'm going to conduct a roll call vote at this point.
Rick, can we just try? And Tom was very eloquent, but it was a little bit long. Can we consolidate this into something a little bit more digestible? Can you just repeat the motion that we're voting on?
Tom, are you the one? So it's a three-part motion. One is the MDPB will provide direction to the EMS providers on their decision-making for the transport of trauma patients, right? And the second is that Central Maine continue to receive interfacility transfers unless there's a neurosurgical piece to it. And then the third is for the 3 trauma centers to come together to develop a longer-term plan for interfacility transfers that they will bring back to this committee in 2 weeks. I think you said 2 weeks, Tom, right?
Correct.
Is that do you feel like that's an adequate representation of the 3?
Yeah, I think that Matt would be able to have the MDP guidance to clinicians about what that means if there's something different than today.
Great, thank you. Brett, is that do what you wanted it to?
Yeah, if Tom thinks that's a true representation, I can vote on that.
Great. Dr. Bowie, did you have a comment on this?
Yeah, just making sure I understand. So it sounds like the second part of that motion is that rather than follow the current plan in place, we would send trauma transfers to Central Maine Medical Center while waiting to get more information. So break from the current plan and do that without data in advance. Do I understand that that's the second part of the motion?
Yes, that is. Yep. Okay. All right, I'm going to conduct a roll call vote at this point. Dr. Scholl.
I'm opposed. Thank you.
Dr. Fenwick.
I have 4.
Dr. King.
I'm for.
Dr. Rappold.
4.
Dr. Tilney.
4.
Director Hurley.
Opposed.
Anna Moses.
Opposed.
Joanne LeBrun.
I'm for.
Tom Judge.
4.
Chris Perret.
Opposed.
Leslie Anderson.
4.
Dr. Bowie.
Opposed.
Chris Costello.
4.
Tammy LaChance.
4.
Julian Tango.
Opposed.
Prep Jorn.
I'm opposed.
And I vote in favor. So it's 1, 2, 3, 4, 5, 6, 7, 8, 9. That's 10 in favor of the motion. 6, 7, and 7 opposed. Motion carries. We will we'll set a meeting for 2 weeks from today. The trauma centers will please work together to come together, review the data, and come up with a plan so that we can present it in 2 weeks. So, Director Hurley.
So just to note, being that that is business of this committee, that is a public meeting, the 3 trauma centers meeting, that will have to be a public meeting or we'll have to pay the fine. And I think that's lacks transparency and is inappropriate. So just letting you know, that will have to be a public meeting because it is business as directed by this committee. It's not just them doing their normal everyday operations. So just putting that out there, that will have to be an open meeting.
Tammy LaChance.
What if we met as the main committee on trauma, not as the state trauma advisory committee?
You're meeting to conduct business of this committee. You were just directed to meet to do business for this committee. So it would have to be an open meeting.
Julian Tango.
So the reason for that is because it was just added to this motion, the motion that just passed.
So the way the open meeting laws work in the state of Maine is if there's 3 members of a committee meeting to conduct business related to that committee, then that meeting is an open meeting. There are certainly going to be more than 3 members on that meeting because all of the program managers and all of the trauma surgeons from all of those hospitals are part of that. And what you're discussing is basically the solution, quote unquote, of what we're going to bring back to the committee. So whether or not you were discussing whether or not we put it in this motion, that's kind of irrelevant. If you went to that meeting to discuss the solution that you were going to bring to this committee, there could be a violation there that was raised, and someone could make a claim that there's a violation of the open meetings law. And so I just want to be very upfront, especially being members of the media and others are on this committee. I am not in favor of violating open meeting law. So we'll have to be an open meeting.
I'm just taking a moment to try to put this in chat so that, oh, yes, thank you, Dr. Scholl. Sorry, I'm trying to put this in, chat for the request that went out there. So,
Rick, how about if you work on this? I'll send you the language. And then
perfect.
You can do the chat.
Thank you, Tom. I appreciate that. For those who asked for it, we'll work on that language for you, and we'll put it in the chat momentarily. Okay. We will need to set up a meeting 2 weeks from now, and trauma center coordinators and directors, please let us know when you will set up a time to meet so that we can follow the rules as put forth by Director Hurley. Is there any other business to come before this group today? Prep Bjorn.
Rick, I might have missed it. I was trying to multitask and I'm not up to that. But have we agreed that when we do have this trauma center public meeting that the data will be available for that meeting?
I believe that Dr. Krupp has said that he will have that data available. Yes.
Thank you.
Is there any other business to come before this committee? All right. Sorry, Joanne, did you have something? Yes. Are you at Central Maine too, Joanne?
No, I'm not actually. So the first part of Tom's motion about the clarity for our EMS community, the MDPB, as I recall, does meet tomorrow. Is it possible to get that conversation on the agenda? I know Dr. Ritter and Dr. Tilney attend that meeting, and I think that they had some good common sense approaches and advice already given to our EMS community based on the operational bulletin that went out by Maine EMS. And so I just wanted to be sure it would be, at least discussed on the agenda tomorrow, and that they'd be, available and to talk about that.
Dr. Scholl?
Yeah, I think by my count, we have about 5 of our MDPB meeting members on this meeting right now.
Mhm.
As the chair of the committee, we do have some discretion to enter in emergency amendments to the agenda, which we are going to meet about immediately after this and discuss.
Okay. Thanks, Matt. Appreciate that.
Great. Is there any other business to come before this committee? Tom, how are we doing with the language?
2 minutes.
Okay. Well, let me just take the opportunity then to thank everybody for participating today. I think this has been a difficult, but very good collegial discussion about the trauma system in Maine. I have had my faith reinforced in the fact that everybody has one single goal, and that is to make sure that patients who are injured in the state of Maine receive the most appropriate care they can in the most timeliest of fashions. So thank you all for your commitment to the trauma system in Maine. And I appreciate you taking times out of your day to meet with us and talk with us here. The only thing left on my perspective is that we will be posting this language from Tom, but if those of you who aren't interested want to sign off, that's okay. I would entertain a motion to adjourn.
So moving your way.
So I've got Brett, and I think Joanne seconded that. Thank you. So the meeting's adjourned. Sam, we do need to stay up for a minute so that we can post this language.
Did you get that, Rick?
Where did you send it?
I sent it to PetSar, and I sent it to nothing Northeast EMS. You need to send it somewhere else.
All right, let me look for it.
You only have about 17 email addresses, so.
I know. It's
Tom, can you copy it in the chat and drop it in the chat?
I could.
Yeah. Thank you, Tom.
My only concern, Tom, is the actual motion was just that the MDPB issue guidance to EMS clinicians. I think that those items that you listed as sub bullets are important, and they will likely need to be what's comprised of that, but that was not the motion that was voted upon. That would be my only concern.
Yeah, that's fine. I think we talked about those earlier.
All right. Are we set? Thank you, everybody. Sam, thank you for hosting this, pulling this meeting together.
Thank you. Have a good day.